Hello students. Welcome to part 4 of the assessment of renal urinary system. So now let's talk about imaging assessment, right? So for the kidney, ureter and bladder x-ray, an x-ray of the kidneys, ureters and bladder is a plain film of the abdomen obtained without any specific patient preparation. That's the most important. For this test, there is no preparation. The kidney, urinary, and bladder X-ray shows gross anatomic features and obvious stones, strictures, calcification, or obstruction of the urinary tract. So basically, some doctors are going to start with this imaging instead of the ultrasound, right? This test identifies the shape, size, and position of the organs in relation to other organs of the urinary tract. The X-ray will be taken while the patient is on supine position. No specific follow-up care is needed. So now we have radiologic and special diagnostic tests for patients with disorders of the kidneys and urinary systems. So we have here the X-rays, right? Is going to be used to assess for the presence of two kidneys, to measure the size. The CT scan is going to measure the kidney size, to evaluate the contour, to assess for injury, masses, or obstruction in kidneys or urinary tract, and to assess for renal blood flow, which is very important, right? The renal blood flow is extremely important. Now we are having the magnetic resonance, the MRI, similar to the CT, but it's usually very helpful to stage cancer, right? Also, we are having the ultrasound, can be used with contrast media to identify the urine volume in the bladder, size of the kidneys or obstruction, if there are tumors, stones in the kidneys or lower urinary tract. So this is the renal ultrasound. Then we have the renal scan, the nuclear, to evaluate for renal perfusion, the glomerular filtration rate to provide functional information without exposing the patient to iodinated contrast medium. Okay, so this is the renal scan, right? I'm going to highlight these ones. Then we have the cystoscopy. So I want you to remember the renal scan, the cystoscopy to identify abnormalities in the bladder wall and urethral, to treat the small obstructions or lesions via fulguration, lithotripsy, or removal with a stone basket, right? This is the cystoscopy, cystography, and cystourethropy. Those are important, but the ones that I'm mentioning at the beginnings are the most important that I want you to remember, right? Metabolic imaging with position emission. Your PET scan is usually to evaluate Sweet's tumor, but the PET scan in general is usually used to evaluate metastasis. Okay, if there is any malignant tumor. Then we have the computed tomography, right? The CT, let's get deep into that. Inform a patient that a CT scan provides three-dimensional information about the kidneys, ureters, and bladder, right? It can provide information about the tumor, cysts, abscesses, other masses. The most common contrast agents used for imaging of the kidney are radiopaque, contain iodine, and non-ionic, and have varying osmolarity. When contrast is used, ensure that there is a sufficient oral or IV intake to dilute and excrete the contrast media. That's why it's so important before this type of exams to request for the CMP, the Comprehensive Metabolic Panel, so you can see how is the function of the kidney, the creatinine, to see if the kidney is working good, because after the procedure, after the test, the patient is going to be advised to drink a lot of water. Typically, the radiologist will specify a total fluid intake of 1 liter of a variable rate to maintain urine output at 1 to 2 mL per kilogram per hour for up to 6 hours. Now, contrast mediums is potentially kidney damaging, nephrotoxic, Contrast-induced nephropathy is the onset of acute kidney failure within 48 hours after the administration of the iodine. So that is very important. This is good to know. This is NCLEX material. You have to tell the patient to drink a lot of fluid, and we need to request the creatinine result from the recent CMP lab work. The risk for contrast-induced nephropathy is greatest in patients who are older or dehydrated, have pre-existing chronic kidney disease, or have comorbidities of diabetes, heart failure, or current hypertension. Now, in addition, patients taking metformin are at risk for lactic acidosis. Another good point, another good to know for the exam is lactic acidosis. It's not ketoacidosis. It's not other type of metabolic acidosis or alkalosis. No, it's lactic acidosis. Lactic acidosis is in reference to the muscles, okay? So patients taking metformin are at risk for lactic acidosis when they receive iodinated contrast media. Metformin should be discontinued at least 24 hours before the time of a procedure and for at least 48 hours after the procedure. So for a total of 72 hours, right? 24 hours before, 48 hours after, and that's good to know. Metformin alert, NCLEX alert. Kidney function should be reevaluated before the patient resumes metformin therapy. Now, safety priority: ensure that the patient who is prescribed metformin does not receive the drug after a procedure requiring IV contrast material until adequate kidney function has been determined. So that means until the patient is having a urinary output that corresponds with the amount of fluid the patient is taking. Best practice for patient safety and quality care: assessing the patient about to undergo a kidney test or procedure using contrast medium. So they are all important. A few of them I will strongly focus will be describe the reaction in terms of hives, facial edema, difficulty breathing, bronchospasm, right after receiving the contrast. Patient with asthma has been shown to be at greater risk for contrast reaction. So we have to pay extra attention to this type of patient. Contrast reaction has been reported to be as high as 15% in patients with high fever or food or drug allergies, especially to seafood, eggs, milk, or chocolate. It's important for the nurse also to have your Benadryl close just in case. Metformin must be discontinued at least 24 hours. We know that because of the risk of lactic acidosis. When have you last eaten or drank anything? That's the question. When have you last eaten or drank anything? Yeah. Assess for a history of renal impairment and for conditions that have been implicated or increasing the chance of developing kidney injury. Now, if you are requesting the last lab work, the CMP, and you're going to see the creatinine ratio, right? The creatinine results, you are already seeing the renal status, right? So that's very important. Take notes if the patient has diabetic nephropathy, class 4 heart failure, which is a very advanced stage of heart failure, dehydration, if the patient is taking nephrotoxic drugs such as aminoglycosides or NSAIDs, and cirrhosis, right? So if the patient is taking NSAIDs like twice a year, that is not a risk, but if the patient is having chronic long-term use, that is a risk. Assess hydration status by checking the blood pressure, heart and respiratory rate, mucous membranes, skin turgor, and urine concentration. Now, IV fluids of normal saline are the most effective before the procedure to prevent contrast-induced nephrotoxic effects during radiologic procedures, right? And that is happening when the patient is having risk, and probably if the patient is in the hospital, sometimes they are going to do that. Diuretics may be given immediately after the contrast is injected, right? to enhance excretion in patients who are well hydrated. Now, let's talk about magnetic resonance imaging. MRI provides improved imaging between normal and abnormal tissue, and we have to pay attention to the gadolinium-based contrast agent that are used with MRI, similar to the CT scans, and the contrast agent is injected intravenous and excreted via the kidneys. So this agent has been linked with nephrogenic systemic fibrosis and should not be used in patients with renal impairment. That's why it's important not only to assess physically or by questioning the patients. I strongly recommend you need pieces of evidence, blood reports, and usually that is the safe practice that many of these places that are doing this type of test are requesting, right? So this agent has been linked with nephrogenic systemic fibrosis and should not be used in patients with renal impairment. We know that. Usually defined as a serum creatinine above 1.5. So that is the definition of renal impairment. That's why I strongly recommend you to review your creatinine levels and have them in your memory, right? If they are above 1.5, it's suggesting renal impairment, right? Or an estimated GFR less than 45 mLs per minute. So glomerular filtration rate less than 45. Now, adults older than 60 years should be carefully evaluated for renal impairment. Now, kidney ultrasonography, this test usually requires a full bladder, right? Ask the patient to drink half to 1 liter of water if needed, about 2 to 3 hours before the test to help fill the bladder. The patient should not boil after drinking the water until the test is complete. This is a very uncomfortable test, especially if the patients are older and they cannot hold urine. The patient undergoing this test is usually placed in a prone position. Sonographic gel is applied to the skin over the back and flank areas to enhance sound wave conduction. A transducer in contact with and moving across the skin delivers sound wave and measures the echoes. So now we have the renal scan. This imaging test is used to examine the perfusion, function, and structure of the kidneys by the IV administration of a radioisotope. It does not use an iodinated contrast agent, and that's the most important. You need to differentiate between the MRI and the CT scan, right? The renal scan does not use an iodinated contrast agent and thus may be used in preference to a CT scan when the patient is allergic to iodine or has impaired kidney function that places him or her at risk for kidney injury from IV contrast. So there's no fasting or sedation preparation for this test. The isotope is eliminated 6 to 24 hours after the procedure. It encourages the patient to drink fluids to aid in excretion of the material, and that's good to know. A renal scan is contraindicated in women who are pregnant. NCLEX alert, that's good to know, unless the benefits outweigh the risk. And then we have the renal arteriography or angiography. I want you to pay attention to this one. Renal angiography allows visualization of the renal arteries using a radiopaque contrast medium that enters the renal blood vessels and generate images to determine blood vessel size and abnormalities. The contrast medium is injected through the femoral or brachial artery as X-ray pictures are taken. Now we have the cystoscopy or cytoureteroscopy. But cystoscopy is important. We are going to watch a very short video about the cystoscopy. Okay, and we are almost done with this chapter. Cystoscopy. Okay, 2 minutes.
Your doctor has recommended that you have a cystoscopy. This procedure is used to examine your bladder for any abnormalities. Your doctor will insert a cystoscope, which is a thin tube with a camera and light on the end, through your urethra and into the bladder. This inside view allows your doctor to look for causes of bleeding or blockage, or any abnormalities of the bladder and its lining. This animation shows how cystoscopy is used to study your urinary tract. Typically, you are awake for cystoscopy. Your urethra will be numbed with an anesthetic spray or jelly, and you may also be given a sedative to relax you. The cystoscope is inserted through your urethra and into the bladder. Your bladder is filled with a sterile solution, and you may feel the need to urinate. After the procedure, you are encouraged to do so. The doctor will examine your bladder for any abnormalities. Sometimes, the doctor might take a specimen of your tissue, which is called a biopsy, for further examination. Your doctor also examines your urethra. In men, the prostate is examined too. Once the cystoscopy is done, you are encouraged to urinate in the bathroom. Your doctor will usually discuss the results with you right away. After a cystoscopy, you might have a burning sensation during urination, or some traces of blood in your urine. It's also normal to urinate more frequently. These side effects should pass after a few days.
Thank you so much. Excellent video. So now we are going to emphasize that this procedure requires completion of preoperative checklists and assign informed consent. That's good to know. The urologist provides a complete description of and reasons for the procedure, and this test is used to examine for bladder trauma, urethral trauma, to identify causes of urinary tract obstruction. Cystoscopy also may be used to remove bladder tumors or plant radium seeds into a tumor, dilate the urethra and ureters with or without stent placement. So it's a procedure that is very important, and you need to master the pre and post nursing education. Stop areas of bleeding or resect an enlarged prostate gland. So a light evening meal may be eaten. Usually the patient is NPO after midnight on the night before the cystoscopy. Bowel preparation with laxative or enemas is performed the evening before to the procedure, so the bowel contents do not interfere with the procedure. So that's good to know. Pay attention to that. Follow-up care we have after the procedure with general anesthesia. The patient is returned to a post-anesthesia care unit or area. If local anesthesia and sedation were used, the patient may be returned directly to the hospital soon. Patient undergoing cystoscopy examinations as outpatient are transferred to an area for monitoring before discharge to home. So it could be done ambulatory as well. Monitor for airway patency and breathing because the patient had anesthesia, changes in vital signs, and in urine output. Also observe for the complications for bladder puncture, excessive bleeding. Excessive bleeding is not live bleeding, and infection is very important because the camera is entered through the urethra, right? Bladder puncture is accompanied by severe pain, including abdominal pain, nausea, and vomiting. So there is a lot to educate a patient. Status post cystoscopy. A catheter may or may not be present after cystoscopy. The patient without a catheter has urinary frequency as a result of irritation from the procedure. The urine may be pink tinge, but gross bleeding is not expected. Again, bleeding. Clots of the presence of clots may obstruct the catheter and decrease urine output. Irrigate the Foley catheter with saline if prescribed. Notifying the urologist if the patient has a fever. That could mean infection, right, or elevated WBC. you need to recommend the patient that he needs to take oral fluids to increase urine output, which helps prevent clotting and reduce the burning sensation on urination. Cystography, these tests are a series of X-ray or a continued radiographic visualization by fluoroscopy. During the image, radio-packed contrast medium fills the bladder and the bladder is empty. Now, how do you prepare for this procedure? Explain the procedure to the patient. A urinary catheter is temporarily needed to instill contrast medium directly into the bladder for both procedures. After bloody filler, X-rays are taken from the front, back, and side position. For the voiding cystourethrogram, the patient is requested to void, and X-rays are taken during the voiding. The cystogram is used in cases of trauma, when urethral or bladder injury is suspected, or for patients with recurring pyelonephritis, which is a kidney infection, pyelonephritis. Follow-up care, monitor for infection, we know that. Encourage fluid intake to reduce the burning sensation. Monitor for changes in urine output because pelvic or urethral trauma may be present. Retrograde procedures, we are going to skip that. Other diagnostic assessment, urodynamic studies like tests of bladder capacity, pressure and tone, studies of urethral pressure, tests of peritoneal voluntary. Cystomegametrography can determine how well the bladder wall detrusor muscle function and how sensitive it is to stretching as the bladder fills. Also, we have, for any procedure that involves inserting instruments into the urinary tract, monitor for infection, okay? And if they are inserting instruments, I would say informed consent. Record the patient's temperature, the character of the urine, and urine output volume. Urethral pressure profile, also called a urethral pressure spirometry, can provide information about the nature of urinary incontinence or urinary retention, but I'm not going to test you on that. Urine stream testing is used to evaluate pelvic muscle strength and the effectiveness of pelvic muscle in stopping the flow of urine. Electromyography of the perineal muscle test the strength of the muscle used in voiding. And also, let's move into kidney biopsy, right? Kidney biopsy, let me see. Kidney biopsy, most kidney biopsies are performed percutaneously through skin and other tissues. And we are going to watch the video for kidney biopsy. We are almost done with this chapter 57 or 60 on the 10th edition. Okay, let's go.
A kidney biopsy involves taking one or more tiny samples of your kidney for observation. Please inform your doctor about all current medications. Blood thinners should be stopped at least 5 to 7 days prior to the procedure. You must undergo prothrombin time and partial prothrombin time blood tests before the test. The procedure is done from the back post-local anesthesia and involves an ultrasound guided gunshot renal biopsy and takes about 20 minutes. You must avoid movement during the procedure. Post-procedure, Dynaplast dressing is done and you must lie still on your back for 2 more hours. You will be under observation for 6 hours post-biopsy and then discharged. Reports will be issued in 5 days. You must be on bed rest for 24 hours more and follow a prescribed renal diet. If blood in the urine is observed, please contact your doctor immediately.
Excellent. So the most important is the risk of bleeding after biopsy, right? Coagulation studies such as platelet count, activated partial thromboplastin, prothrombin PT, and bleeding time are performed before the surgery, right? And for this procedure, the patient needs to sign an informed consent, and patients are NPO for 4 to 6 hours before the procedure. Now, hypertension is aggressively managed before and after the procedure because high blood pressure can make stopping the bleeding after the biopsy more difficult. Uremia also increases the risk for bleeding, and dialysis may be prescribed before a biopsy. So a blood transfusion may be needed to correct anemia before biopsy. So all these facts in these first paragraphs are good to know. NCLEX alert, right? Follow after the percutaneous biopsy, the major risk is bleeding into the kidney or the tissues external, right? So for 24 hours after the biopsy, monitor the dressing to see what is the amount of bleeding, right? And also check for the blood pressure, urine output, hemoglobin level, and hematocrit. An internal bleed is not readily visible, but is suspected with flank pain, decreased blood pressure, decreasing urine output, yes, and other signs of hypovolemia or shock. This is basically with all type of procedures when internal bleeding is present. With severe bleeding, some patients develop bruising along the flank, and the patient follows a plan of a strict bed rest, lying in a supine position with a back roll for additional support for 2 to 6 hours after the biopsy. The head of the bed must be elevated, and the patient may resume oral intake of food and fluids. After bed rest, the patient may have limited bathroom privilege if there is no evidence of bleeding. You have to monitor for hematuria. The most common complication of kidney biopsy, and that's good to know. This problem usually resolves without 48 to 72 hours after the biopsy, but can persist for 2 to 3 weeks, depending on the amount of bleeding, the character of bleeding. Okay, if bleeding occurs, IV fluid, packed red blood cells, or both may be needed to prevent shock. In general, a small amount of bleeding creates enough pressure to compress bleeding sites. This is called tamponade effect. If tamponade does not occur and bleeding is excessive, surgery for hemostasis or even nephrectomy may be needed. And these are in extreme cases, but that's why you need to follow and you need to monitor. Okay, with this we have concluded chapter 57 on the 11th edition, or chapter 60 on the 10th edition, related to assessment of renal or urinary system. Thank you so much.